Welcome back to our third episode of 12 in this learning journey on eye care and eye care for children. I have Dr. Sophia Capo of ABC Optometry and Vision Center in studio with me today. Welcome again. Thank you very much.
Thank you for having me again.
So last week we talked about clarity, and this week we're going to talk about coordination.
Yes.
So this is going to be a very interesting education topic. The first one is convergence insufficiency.
Yeah, just convergence challenges in general.
Okay.
So I'm really happy you made that distinction, because last time we were talking about clarity, which is just, how good can a person see? Like, can they see 20/20? Whereas these are things that we're going to talk about today that aren't clarity related, but affect clarity indirectly. So convergence insufficiency is a very common one. I think the number that's going through the literature right now is 8%. So about 8% of the population has this, almost 1 in 10. And essentially what convergence insufficiency is, it's difficulty with the way the eyes are moving, with the way the eyes turn in. So when you're looking at something straight ahead, your eyes have to stay straight. But when you look at something up close, so like if you look at me and I'm trying to look at my finger, my eyes have to turn inward in order to see it. Now, the motion of our eyes turning in is called convergence.
Makes
so
sense.
Throughout the day, every time we look at something, so every time we change our gaze from looking far, looking close, trying to read, our eyes have to do this inward turning motion. Okay. Now think of everyone's eyes as having a posture. So just like, sometimes we sit up straight and sometimes we slouch, eyes can do the same thing. So some people have, we'll call it slouchier eyes than other people. Okay. So let's say I have a slouchy eye posture and my eyes like to turn outward. So they like to sit in a slouchy outward position. If I have to now turn my eyes inward to look at something up close, let's say to read, my eyes have to do a lot of work. So my eyes have to go from
to cover.
Exactly.
Okay.
So it's like someone who doesn't have slouchy eyes only has to go from straight to in, whereas someone who has really slouchy eyes has to go from all the way out to all the way in. So they have to do more work in order to do that. Now, someone, for example, who is struggling with a convergence insufficiency, so whose eyes have a hard time turning inward, we find that they have difficulty with reading. So difficulty with keeping their eyes attentive to read. Now, sometimes what adults would tell us are, words are moving around on the page. I skip lines when I read. So the words are sometimes blurry and they're sometimes clear. Sometimes I get headaches when I read. Sometimes it's hard to comprehend what I'm reading. And that's because in addition to having to overdo this posture, so like overcome that posture, we also have a stamina. So think about it as like...
This is fascinating.
Think about it as like we're at the gym and we want to do a bicep curl. So let's say I can hold 5 pounds on a bicep curl, but my max weight is 5 pounds. So like the max that I can do is 5. I'm not going to be able to do very many reps with that 5 pounds because that's my maximum amount that I can hold. So think of the vision system the same way. So in office, what we do is we test how much stamina someone has. So I put weights over the eyes, over the visual system, and I see how much weight can I put before the system breaks down. Now, someone who has a really slouchy posture, who already has to do more work than average, if they have really low stamina, well, they're not going to be doing super well to read.
No.
But someone who has, even if they have a slouchy posture, if they have a large amount of stamina, then they can overcome that posture and they're going to read successfully. Now, you can imagine in a convergence problem, your eyes have a hard time turning in, but they're not completely misaligned. They are just struggling to stay aligned, which is why sometimes people will say, it's not really double vision. Double vision happens if our eyes are fully misaligned. but it's like sometimes double, or things look like they're moving a little bit. And that's because, if we have two things that our eyes see, this here would be single vision.
Yeah.
This would be double vision. But if our eyes have low stamina and, they're trying really, really hard to stay single, and then every so often it's shifting into the double, but then, they try really hard and the system pulls it back together. So that can cause the words to be moving, or the words to be going sometimes blurry and sometimes clear. Because that little shift in double, children won't say that that's double vision, because it's not. It's not two of something. But it's off. And so it's almost like a shadow. And kids will say, well, it's sometimes blurry, but it's not all the time. And so even though we're perceiving this as, a child might say it's blurry, it has nothing to do with clarity and everything to do with the way our eyes are actually working together and coordinating. Now, two healthy eyes. This is not a problem with the health of the eyes. So like the eyes are perfectly fine. The muscles in the eyes are also perfectly fine. If the muscles in the eyes were having an issue, we wouldn't be able to kind of look up, down, left, right. But we can do that. So it doesn't have anything to do with the health of the eyes. It has everything to do with how the eyes are coordinating. Now, a really good analogy that one of my mentors taught me was, just because you have two healthy feet, I have 2 feet that work, it doesn't mean I can dance. And that's because dancing is very coordinated, right? Okay. Dancing involves higher order movements and coordination, but my feet are healthy. And it's the same thing with our eyes. Just because we have 2 healthy eyes doesn't mean our eyes are able to coordinate together to comfortably read. Reading is a very complex task.
So what I find so interesting about this test or this condition, is that a right terminology?
Yeah, it is. It is a medical diagnosis.
So what I find fascinating about this condition is the fact that I think a child may have a difficult time articulating this in a way that a parent could understand that there may be something there. And I love that. So is this part of the gold standard that we talked about last week?
Yeah, we should
testing.
For my test, this is part of the gold standard. Okay. So we're looking at how the eyes are moving, not just how clear a child might be seeing.
Okay.
And that gives us a lot of insight for their function. And so sometimes, a parent may not even know to mention something like that to me as an optometrist. So I go above and beyond to ask those questions. So it's I'm asking, I'm looking at this and the child looks like they have a really slouchy posture. They look like they're not compensating well for that posture. And so I'll just ask, how are you doing in reading? Do you like to read? And the kids, they might be like, oh, I don't really like reading. It's terrible. Or I'm like, okay, well, why? Is it because reading is hard, or is it because you don't like it? Well, reading is hard. Well, let's unpack that a little bit. And sometimes I've had parents like tear up sitting in the room when I ask their child, do you ever see 2 when there's only supposed to be 1? And the kid says yes. And the parent goes, oh my goodness, this whole time, we're being investigated for ADHD. We're being investigated for all these attention problems. And those things, again, like we talked about last time, they might be coordinated. Sure. So children with ADHD have higher rates, like more than 8% of convergence insufficiency. But you can imagine we're not setting up these kids for success. These are barriers that we can remove by addressing an eye coordination problem. If a kid's, no longer seeing double, they're going to have a lot easier of a time in school than if they were.
You explain these in such a beautiful way. We can actually understand what you're telling us.
I have lots of practice.
It's so good. So our next condition is...
you can do it.
I can do it. Strabismus?
Yeah, you got it.
Okay, and that's eye turns.
Yeah. So strabismus is an eye turn. Different from a convergence issue. So someone who has a convergence problem, they might have a slouchy posture. They might have low stamina kind of to get that posture to stay aligned, but it doesn't often completely misalign. So a strabismus is someone who has a complete eye misalignment. So these are the people who, when you're looking day to day, you can see one of their eyes is wandering.
Okay.
And we have 2 different types of wandering eyes. So our eyes can wander outward. That's called an exo posture, or our eyes can wander inward, which is called an eso posture. So we have those out and in. types of strabismus. Now, strabismus can be constant, so it can be something that's there all the time, that's very noticeable, or it can also be intermittent, which means it's only there sometimes.
Tired.
Now, yes, exactly.
Okay.
So strabismus also has a stamina component. So if, let's say I'm a child and I have a strabismus, but it's intermittent, it means that my eyes want to be misaligned. Maybe they're almost misaligned, but I'm holding it in with my small amount of stamina.
Okay.
But then there are points in times where there is a true misalignment. And that's the difference between a convergence insufficiency. In a convergence insufficiency, you wouldn't see a true turn.
Okay.
Strabismus, again, like you mentioned, fatigue is a really big component. So an eye turn outward, an exo-postured strabismus is really common in young children. Especially, we have high risks if we were born prematurely or if in the autistic group, in the ADHD group. And parents will come in and tell me, it's always at night when they're tired, I'll see their eye kind of wandering out. And if you call attention to it, hey, look at me, bring your eyes over here, they can do it. But sometimes it turns out. And we have this even, I'm sure, at parties, when we were younger and going out, we would see someone who drank too much, they would lose the control over their eye turn, and their eye turn might wander in or outward. So it's a fatigue problem. It's a stamina problem. Now, some forms of strabismus we can manage, and we can manage from an optometry standpoint, using some sort of glasses or using a special type of lens called prism. But a lot of strabismus ends up going to an ophthalmologist who is a medical doctor, an eye surgeon, for strabismus surgery. So a surgery that actually kind of moves the muscle to align the eye better cosmetically. Yeah. If it's for example, a constant eye turn, we want to align the eyes better cosmetically. We know from a lot of studies that kids are incredibly cruel when it comes to bullying over eye turns.
Oh my gosh.
And so it's something that
Capo,
needs to be addressed sometimes, simply because of that. Or in adults, sometimes adults are born with the eye turn. And then over time they lose their control. So it gets worse and worse and worse. It's noticeable. A strabismus surgeon just kind of makes it look more aligned.
Okay. So then our third condition is amblyopia.
Yeah.
Amblyopia. And that is our lazy eye.
Yeah. So amblyopia is a lazy eye.
Okay.
Now, eye turns and lazy eyes are often confused.
I'm confused.
Yeah, you're confused already.
I'm confused.
So usually when you see someone who has an eye turn, someone will say, their eye is lazy. And that makes sense intuitively, because if the eye is not playing along and it doesn't want to stay straight, it seems like lazy would be a good word to describe it. But clinically, lazy eye is the lay term used for amblyopia. Now, amblyopia means that the brain has not made a good connection with that eye for whatever reason. So I'm going to give you two examples, the most common two examples of where someone would develop amblyopia. So let's say I have a really big glasses prescription in one eye, and I have a smaller glasses prescription in my other eye. My brain only gets clear vision from one eye. And so the brain says, this other eye isn't quite working. There's something wrong with it. So I'm just not going to build the network between the brain and that eye, because that eye is too difficult to see with. Now, this only develops in childhood. So it's only something you can get as a kid. So if you're an adult and you just have two different prescriptions because let's say you had a cataract surgery and it's different, you won't develop it.
Okay.
But in a kid, if I have a high prescription in one eye and then a low prescription in the other, the brain is going to favor the eye that's closer to zero, the eye that's easier to see.
Makes sense.
Yeah. So our brain is really cool.
It.
The brain does some really cool things. But the brain is going to favor the eye that's lower. And so what happens is, even after you put glasses on, so let's say a child went 5-6 years, they had a different prescription, their brain started ignoring the eye. Even after you put glasses on them, glasses doesn't solve the problem because the network isn't there.
Yeah, okay.
But putting glasses on them actually makes the network stronger. So once you get the glasses on that child, the brain says, oh, I can actually see with this eye now. So maybe I'm going to start forming this network.
Okay.
And so you'll see children who have to wear an eye patch. or there's a lot of kids who have been recommended to wear an eye patch.
Yeah.
And that's because when one eye is not being favored by the brain, you penalize the good eye by covering it, and you force the brain to say, hey, this one works too, you should use it.
Fascinating. And that's why I'm understanding there's a short window to patch.
So
is that
yes.
correct?
So
Myth? True?
no, so it's kind of being debunked now that there are studies now of adults who have had amblyopia from childhood, who are doing different therapies to try and improve the vision in their eye, and they work. But we'll call it more of like a sensitive period. So when you're under the age of 7, it's way easier to fix than when you're older than that. It's still possible. Yep. It's just more complicated, probably not going to get as good of a fix, and probably going to be a lot more time consuming, maybe more expensive to try and do it. But when we're young, it's very easy.
So each of the last two conditions are obvious-ish for us parents to detect?
So the amblyopia is, it depends. So if it's because of a prescription difference, a child will almost never tell you that they can't see out of one eye. And that's because no one's going around comparing their eyes. So a child's not going to come home and say like, hey, this eye is blurry, but this one sees really well. Children with amblyopia, because of prescription, usually say absolutely nothing. And it's usually us who find it when they come to the optometrist and we're comparing one eye versus the other and we go, oh no, this eye's not seeing so good comparatively.
Okay.
Now, the second type of amblyopia, the second type of lazy eye, is from a strabismus. So again, amblyopia means that the brain is not forming those networks with the eyes.
Okay.
So if I have an eye turn that's constant, so let's say I have an exoposture eye turn, it's turning outward and it's there all the time. My brain does not want to recognize that outward turning eye because it is very, very complicated to do so. Because if the eyes aren't pointing at each other, that's double vision.
Yes.
So if both eyes are pointing at something different, the brain is going to see two. So what the brain does is it says, this one's misaligned. I'm just going to not use it and not build those connections between the brain and that eye. Those ones parents usually catch because if the eye is all the way turned, the parent says something doesn't look right. I'm going to bring them in. And usually we can manage that type of amblyopia because we catch it earlier. But it's the ones with the prescription differences that usually aren't caught until someone comes in for a routine exam, which is why, again, if we're coming in when the academies are recommending, so at 6 months, I can already see, okay, these two eyes are about the same prescription. So I'm not worried about a lazy eye. And then I can see at age 6 months, these eyes are straight. So I'm not worried about a strabismus. Now, kids' eyes are supposed to be misaligned before age 6 months. Not supposed to be. I guess that's the wrong way of putting it. They often are, and it's not a problem. Yeah. So if it is, we wouldn't really worry about it.
No panic button.
No panic button. But at the 6 month mark, that's when, if the eyes are misaligned, if we are seeing some sort of a strabismus, even an intermittent one that's there only sometimes, we want to get that looked at immediately. Because the faster we find things, especially when the brain's trying to make connections, the faster we can facilitate those connections being made, the easier it is to make sure that the brain just makes those connections.
Of course, correct.
So someone who we call it a risk for amblyopia. So if a child comes in and we have a difference in the eyes in the glasses prescription, before we can even test to see what their true visual clarity is in the office, because let's say they're 1 or 2, we put glasses on them because we say this is a big enough prescription to cause the brain not to make those networks with the eye. And so we put glasses on them. And then amblyopia never comes. So we know who's at risk for it, and we can actually prevent it by seeing the kids earlier and by doing these things properly. And this is another area where those dilation drops that we talked about and accurately assessing the glasses prescription is so important, because kids, especially when they're 6 months to 3, they don't like to sit still and look perfectly straight for you. But when we put those drops in their eyes, we get an accurate measurement every time. Because it doesn't matter where they look. It doesn't matter if we're upside down or tilting to the side. We can still get a measurement to know, are risk factors for these present? And do we need to be managing them sooner?
So every single episode that we've done together leads me to the same conclusion, that is to get the children in to see you, to have a gold standard test done so that we can get baselines and ensure that we're
finding these
anything
things faster.
Yeah,
definitely. And we're going to talk about how to treat these things with something called vision therapy.
Okay.
Which is kind of like physiotherapy for the eyes. That is the gold standard treatment for convergence insufficiency, that first one that we talked about. And it is a secondary treatment for strabismus and amblyopia. But we'll talk about that on the next one, because it is a longer topic, and sometimes can be a little bit controversial. So I want to talk about that. Give it some time.
Yeah. Dr. Capo, I cannot tell you how much I truly enjoy the education and the way that you teach.
Thank you.
For our littles, and appreciate you coming into studio. Thank you.
100%. Thank you so much.